Those of you just joining us, welcome to the 17th Annual Cosumnes River College and Sacramento State Center for Practical and Professional Ethics Fall Ethics Symposium, the ethics of providing healthcare. My name is Rick Schubert. I'm Executive Director of the CRC-CPPE Fall Ethics Symposium series. Chairing our first session is Hema Asan, an honor student at Cosumnes River College. Hema?
Good morning, everyone. Thank you for being here. The first session of our symposium is entitled Facing Goliath, How State Policymakers Can Address the Harms from Healthcare Consolidation. Our presenter is Katherine. Dr. Gudiksen is a senior health policy researcher for the Source on Healthcare Price and Competition. She is a recent graduate of UC San Francisco, UC Hastings, Master in Science and Health Policy and Law program, where she studied policy solutions to promote competition in the pharmaceutical industry. Prior to joining The Source, she co-founded a cancer diagnostics company and worked as the director of technology, where she worked to develop technologies to detect biomarker signatures for aggressive prostate cancer. She also holds an AM and PhD from Harvard University and a BS and BA from Hope College. Our session will be 1 hour and 20 minutes long and roughly divided equally between our speaker's presentation and the question and answer portion with you, the audience. As a segue between Dr. Gudiksen's session with you, the audience, and the open Q&A, we'll briefly hear from two formal respondents, Danielle Adarimi, my fellow CRC Honors Program student, and James Bailey, an associate professor of economics at Providence College, a visiting scholar at the Federal Reserve Bank of Philadelphia, and a senior affiliated scholar with the Mercatus Center at George Mason University. Please join me in welcoming Dr. Gudiksen to the podium. Thank
you so much for inviting me here today, especially to Kyle and to all the organizers. It's actually a really special opportunity for me because a lot of my work is sort of detailed policy, kind of wonky work, and it's unusual for me to be able to have the opportunity to put it in a bigger context, to sort of explain why we're doing what we're doing it, and the ability to keep our lens clearly focused on things like ethics and equity that are so important in healthcare delivery system, and have the potential to be lost in some of the policy, detailed policy decisions. But I'm excited to talk to you today about the kind of work we're doing at The Source. We're a fully grant-funded organization that sits at UC Hastings College of the Law, and we do a lot of policy papers. Typically, our audience is state policymakers and their staff. I wanted to start today by asking really a basic question. Is the US healthcare system working? And I'd argue that by almost any measure, the answer is a resounding no. We pay more for healthcare than any other of our peer nation, other high-income nations. You can see us all the way over here on the right. And also on almost every quality measure, we also perform substantially poorly than any other country. This comes from the Organization for Economic Cooperation and Development, the OECD. And they claim that not only does the US have the most expensive healthcare system in the world, but we rank last overall in terms of healthcare outcomes. And the problem of high cost and low quality are particularly acute for BIPOC and other historically disadvantaged communities. This data is from the Commonwealth Fund, and I know it's a busy slide, but I want to point out that it shows that in every state that actually has data, Black people, those are the green dots, and Native American people, those are the black dots, are more likely to die early in life from conditions that are treatable with timely access to high-quality health care. And I could go on and on. There's lots of data about them being more likely to die from complications of diabetes, higher infant and maternal mortality rates. But the data is very clear. And in addition to these profound racial disparities, the US has significant access issues for low-income Americans. And again, we're dead last among OECD countries in providing access to low-income individuals. In a recent survey in California by the California Healthcare Foundation, half of Californians skipped or postponed necessary care in the last year due to cost. And of those people that skipped care, half of them reported that their condition worsened and their health suffered as a result of missing that care. And the results were even worse for low-income Californians. Almost 75% of people below 200% of the federal poverty level deferred care. Now, I could go on and on this morning about how the US healthcare system is failing to provide Americans with the healthcare they deserve, but instead I'd like to strike a more optimistic tone. I'm going to spend a few minutes dissecting why this is the case, but I want to spend the bulk of my time talking about our work with policymakers at the state and federal level, about what they're doing, what they can do, what they're looking to do, and how we're going to make change. The first thing I think it's important to point out that the US healthcare system isn't really a system. In the US, we have a complex mixture of public and private payers. So in the yellow third there, you can see that includes Medicare, Medicaid, the VA, TRICARE, essentially anytime that the government is functioning as the payer of healthcare. And then there are two blue wedges. The first is Americans, this is percent of people. These are Americans who get their insurance coverage through their employer, and you can see that that's about half of all Americans. And then the other 7% purchase insurance for themselves, typically on the state insurance exchanges, but they can also buy off-exchange insurance. Additionally, in the US, most providers, by that I mean hospitals and doctors, are private. So in the commercial market, standard economic theory tells us that if the markets are functioning, companies will compete to produce higher quality products at lower costs. And in healthcare, this competition should exist at three different places. So providers should compete to provide high quality, low cost care so that insurers will want to include them in their networks. Then second, there's competition among insurers who put together these networks of providers, and they sell their plans to employers and individuals as insurance products. And finally, then, there's competition among providers for patients in their network. So among, for example, all the Blue Cross enrollees, providers will compete to provide better care to their patients. Often this is not a competition based on cost, but rather things like patient experience or quality. But I'm going to show that in all three of these places, the market is simply failing to deliver value. And there's overwhelming evidence that these healthcare markets aren't working. We have high prices, we have highly variable prices, we have very real concerns about quality, and there's evidence of a lack of innovation, especially among sort of hospital care. But I do, when I want to show just how broken I think the US healthcare markets are in one slide, I often present this. So you can see here that on the left, these are the costs of joint replacements. So at Sutter Health, at CPMC, this is in my neck of the woods in San Francisco, you can see that people pay between $23,000 and $102,000 for the exact same joint replacement at the exact same hospital. So there's no difference in quality. The person who paid $102,000 or their insurance paid $102,000 isn't getting anything more for their money than the person who paid $23,000. The only difference here is the ability of the healthcare system or of the health system to charge those prices. And you can say that there's similar data across a whole bunch of conditions. I presented C-sections here as well, where there's actually a tenfold difference at that same facility. These dramatic price differences and lots of other robust economic studies show that in healthcare, prices have essentially no correlation with quality. And that also means that hospitals have no incentive to improve their quality. They're not going to get paid more or get more patients if they improve their quality. So the market is really failing at all levels. So why? Why is the US have such a poor performing healthcare system? And the answer, I'll argue, and a lot of other experts argue, is consolidation. The consolidation into these giant health systems with market power is the reason that we pay so much more and we have lower quality than other countries. So this data shows prices in California from 1995 to 2016, and it shows that hospitals in the largest system, that's the teal line here, charge the highest prices. The yellow line is the other hospital systems. And that the difference between those two lines, the difference is shown in red, that's been growing over the past few decades. This consolidation is actually market-wide. So what I'm presenting here is a measure of the Herfindahl-Hirschfield Index, the HHI. That's a measure that the federal regulators, the FTC and the DOJ, use to identify markets of concern, markets that they think are highly consolidated, and they're going to look more carefully at additional mergers. And you can see that 90% of markets in the US back in 2010 had hospital markets that were already of concern. That means in 90% of the places in the US, the FTC thinks the consolidation is concerning. It's highly concentrated. And so you can see that this has been going up over time across the country, with sort of the biggest increase lately among physicians. And this is just showing some other data from the Congressional Budget Office that shows that, that physician consolidation has been going up rapidly as well. There's an Avalier study from January of this year that found that 74% of physicians practicing in the United States are now employed by a hospital, a health system, or a corporate entity like a private equity firm. And so how do we get here? So one answer is that for 20 years, from 1991 to 2011, the FTC did not win a single case to try to prevent a hospital merger. And there was a period of rapid consolidation, and the FTC basically moved most of their resources to other industries. Now, more recently, they've had much more success, but healthcare markets are already simply too concentrated to function effectively. Now, before I review all the economic studies, I'm going to give you the 5-minute tour of a lot of the economic studies. I just want to make sure I distinguish between different types of mergers. Now, horizontal mergers are mergers between two entities that actually compete with each other in the same space and the same level of the supply chain. So this could be two hospitals in the same city merging together. Vertical mergers are mergers that happen between companies at different levels of the delivery system. So an example here would be a health system acquiring a physician practice or a clinic. And finally, there's cross-market mergers. These are mergers in which the merging entities don't compete for patients. So for example, if a hospital in an urban center bought a rural hospital, or for example, there was the recent merger between an insurance company like United Healthcare that purchased a number of physician groups for their Optum subsidiary. And so I'm going to give you the very fast tour here of the economic studies. And I don't really want to get into the details. I've put references here for anyone who's interested. But the preponderance of the evidence is crystal clear. Horizontal price mergers lead to significantly increased prices, lower quality, and even affect the job market by decreasing wage growth for nurses and pharmacists. And the data is similar for physician horizontal mergers. For vertical mergers, the story is essentially the same. Lots of research groups have found increased prices with little quality improvements. I just want to emphasize here that hospitals or health systems often justify this kind of merger by promising more integrative services and reducing wasteful spending. But 2 recent studies show just the opposite. The physician groups that purchased by health systems refer more care to that system, so more of the care is then delivered at the hospitals, and that the odds of wasteful care increased greatly. For example, one study found that the odds of a patient receiving an inappropriate MRI referral, that's an excessive MRI, they increased more than 20% after their physician transitioned from independent practice to hospital employment. Furthermore, the FTC have had very limited success at challenging vertical mergers in healthcare, so the vast majority of these mergers go unchallenged. The final type of merger, cross-market mergers, have really not received much attention because traditional economic theory sort of suggests a very minimal effect because there's no competition for patients. But an emerging body of research suggests that hospitals can increase their prices following a hospital merger, a cross-market merger. And I don't just mean the hospital that got acquired. The acquiring system also raises their prices, and there's evidence that other hospitals in those markets shadow price those increased prices. So if a merger happens in a market, other hospitals can benefit from higher prices from that merger. And I will say this type of merger has never been challenged in healthcare by the FTC or DOJ. So they can essentially happen without oversight. So what can policymakers do about the provider market power? There are 2 ways that policymakers need to act. And the first is to better oversee market consolidation and to block any mergers that have the potential or have significant likelihood of harms to consumers. And the second is to acknowledge that in many places, blocking future consolidation will have a minimal effect. And it is important to restrict the use of extant market power. So the first step is more effective oversight from the federal government. Mergers of healthcare providers are reviewed by the FTC, and Chairperson Lena Khan has taken a much more critical view of mergers, especially mergers in healthcare. The FTC recently commissioned a report on hospital acquisitions of physicians and has subpoenaed information from large commercial insurers to conduct that review, and I eagerly await the results of that report. And after 2 decades of failure, the FTC is having increased success at challenging hospital mergers, and they've only lost a single hospital merger case in the last 10 years. But of the 1,887 hospital mergers that were announced between 1998 and 2022, the FTC challenged less than 20. So that's less than 1% of the hospital mergers were challenged. And while the FTC has the authority to break up anti-competitive mergers after they happen, they've never done it in healthcare. It's simply too difficult, they claim, to unscramble the egg, which means that they really need the chance to review these mergers before they happen. So federal law requires companies, any companies, to file a report with the FTC or DOJ 30 days before a merger if the transaction is above the Hart-Scott-Rodino threshold. In 2022, this threshold was $101 million. But Irving-Leving data shows that the median hospital deal over the last 20 years was approximately $50 million. So you can see how few of these hospital mergers actually get reported to the feds. So some states have stepped into the void. Most nonprofit hospitals have to file notice with a state AG or some other agency, like a certificate of need program, before a change in ownership of control. Often this isn't really an examination of antitrust concerns, but some states, like California and Rhode Island, the AG can block a merger administratively if they deem that that merger is not in the public interest. But just having a notice of mergers helps states review these mergers more effectively. 3 states, next slide, Massachusetts, Oregon, and California have actually created commissions to better oversee healthcare consolidation in the state. And Massachusetts requires any large provider organization to provide the Health Policy Commission with a notice of material change at least 60 days before any transaction. Then the HPC conducts a cost and market impact review to review the likely impact of the proposed transactions on cost, quality, and access to care. And the HPC then issues a report based on their findings. Now in Massachusetts, the AG still has to go to court to block the merger, but because they have the HPC's research and detailed reports, they have a much greater chance of success, and judges often find those reports very persuasive. California also created an agency, the Office of Healthcare Affordability. They actually had their launch party 2 days ago on Wednesday here in Sacramento, so this office is brand new, and they'll begin reviewing transactions on April 1st, 2024, so I really can't comment too much on how effective this will be. They haven't even issued regulations yet. But I want to spend just a minute on Oregon, because I think in some ways this is the big story in state-level review of merger consolidation. So in July of 2021, the Oregon legislature gave the Oregon Health Authority the ability to actually review transactions and then give a thumbs up, thumbs down, or place conditions on any merger. And furthermore, it goes beyond just mergers and acquisitions. They can review joint ventures and affiliations, anything where the 2 parties are above $10 million in patient revenue. The review process began on March of 2022, and the review is also not just based on traditional antitrust theory. They review transactions based on cost, access, quality, and equity. So in theory, this agency has the authority to begin to address some of the disparities in the healthcare system. And in particular, they have the ability to place conditions on mergers in which they could, for example, demand more culturally competent providers at given facilities. They could demand that facilities in disadvantaged communities remain open. The kind of conditions that the federal regulators, they're so detailed that the FTC or DOJ wouldn't want to get into those kinds of conditions, but a state agency that's used to reviewing the way healthcare is delivered on the ground could really be pretty effective here at those reviews. But I come back to my original point, that healthcare markets are simply already too consolidated. So you can put up, whatever analogy you like. The train has left the station, the horse has left the barn. Many of my colleagues have their own favorite analogy. But in many cases, it's just simply too late. So then I think it's really important for policymakers to focus in this second bullet point here and think about ways to restrict extant market power. And the Congressional Budget Office just came out with a report in September on this exact issue. And they grouped policy interventions or policy approaches into 3 categories: promoting price transparency, which they thought would have a minimal effect, promoting competition among providers, and capping the level of price growth. Now, I want to talk about each of these in a little bit more detail, so I'm going to take the first one and say, that the federal government is taking a very active role in demanding more transparency. The data from from these rules actually is where I got the data that I showed you the disparities at Sutter Health and among the other health systems earlier. And also, many states have created all-payer claims databases. These are databases that are large-scale and collect healthcare claims data from a variety of payer sources, both public and private, and some healthcare providers. Originally, a lot of people thought that these APCDs were going to be the panacea of healthcare because they were going to let patients shop for cheaper care and find the highest quality providers. And I would say they've been pretty much a failure on that front because very few patients shop for care. If my doctor tells me I need something or my child needs to go see a specialist, I don't get on some big database to try and figure out if I can get a slightly better deal, right? That's just not the way things happen in healthcare. Most people go to where their doctor refers them or their friends have had a good experience, say, with a provider. So I think transparency as a shopping tool was perhaps oversold. But what I think is much more important here is for assessing where the particular problems are. So identifying either health systems that are very overpriced or regions of a state where there's real equity problems. I think an APCD could really help identify those. And then there also should be very good at assessing policy interventions. How well is what we're doing working? What can we tweak to make sure that we're not leaving behind one particular community who's been disadvantaged? But since I think that transparency efforts overall are going to have a pretty small effect, I'm going to move to the second, promoting competition among providers. Now, at the federal level, one of President Biden's first executive orders was on promoting competition in the American economy. I want to pause for just a minute to give you a sense of what a big deal this was. So let me take you back to July 9th, 2021, and remind you that this was just 6 months after he took office, after the January 6th insurrection, and there'd been lots of discussion in Congress. Congress was really thinking about whether there should be investigations or what they could do about this. We were also in the midst of the coronavirus pandemic. This was when the Delta variant was surging. And it was a year, it was amidst the most dramatic racial protests that most of us can remember. The National Guard had just been deployed in Minneapolis because the Derek Chauvin trial of the murder of George Floyd was going on. And yet, in the midst of all this turmoil in the country, President Biden took the time to write an executive order and frankly gave an impassioned speech about the need for renewed antitrust enforcement and put together a whole-of-government approach that was created a new competition council. He tasked a dozen state federal agencies with reinvigorating competition and called out agriculture, technology, and healthcare as industries of the highest concern. So you can see that there's a lot of value placed on this at the federal government. And at the federal level, I think there's been a lot of inaction across the board writ large, but I'm hopeful that this sort of emphasis may get some traction at the federal level. Last year, our team did a deep dive into contracting practices that large health systems can use to drive up healthcare costs. For example, there's a famous handshake in the snow between Partners Healthcare in Massachusetts and Blue Cross, where Partners agreed to give Blue Cross the best rates, that they would charge all other insurers more. And then Blue Cross agreed that they were going to increase the amount that they paid to Partners. So both benefited, and Blue Cross was very willing to increase what they were paying to Partners because they knew all their other competitors were going to get an even worse deal. So all the insurers could just pass these price increases on to employers, to patients, to people buying healthcare. And this market agreement led to significant premium increases of almost 9% a year. Similarly, dominant health systems in North Carolina and California allegedly refused to join networks unless the insurers agreed to take all of their hospitals, even where there were lower cost, higher value alternatives. And they demanded that the insurers not even tell patients if they could have gotten better care for less money at another facility. So these contract terms are called all or nothing terms and anti-steering provisions, and they effectively tie the hands of insurers who want to steer enrollees to more more cost-effective, higher value care. So these contracting practices have been the subject of antitrust lawsuits. Sutter's probably the most famous among this room, and in that case, a group of employees and the state AG alleged that Sutter used a combination of these all or nothing contracting terms, anti-steering clauses, gag clauses, and excessive out-of-network pricing in ways that violated state antitrust laws. In 2018, a judge approved the settlement that included $575 million in damages, one of the largest damage suits in this area, and injunctive relief that prevents Sutter from using these contract clauses in the future. To try and level the playing field and not have to go to court every time any health system allegedly uses these terms, a few states have considered laws banning these contract terms. And in the light color, you can see states that considered a bill. That means they didn't pass the law, but the legislature actually had discussions about these bills. And I'm excited to say that in Nevada last year, it became the first state to prohibit all or nothing contracting, and the second state after Massachusetts to ban anti-tiering or anti-steering clauses. And the savings from these laws can be substantial. Massachusetts, the anti-steering, anti-tiering law has been in place for about a decade, and one economist used data from Massachusetts to estimate that if the laws in Massachusetts were spread nationwide, we'd save 12% in healthcare costs just by eliminating these contract terms. Similarly, 20 states ban MFN clauses. Those are the kinds of clauses that are like that handshake in the snow I described, where two parties get together and agree to give each other the best deal. And 6 states, I didn't really talk about these, 6 states, including California, ban gag clauses in health insurance contracts. So I think it's really important to improve competition, but these laws and better antitrust enforcement is really only going to go so far. So I think it's important to at least think about the third level of options. And I'll say this has sort of been the third rail in health policy for a long time. Nobody likes to think about the government setting what we pay for prices. But I hear a lot more conversation about it, at least in health policy circles. I'm going to show you, next one. I'm going to show you a number of options. We just published a paper in September about these, and you can see that there's a whole range of options here. And at the far right are policies like actually setting prices. But at the far left are ways that put a little pressure on commercial prices without actually capping prices. And we think that some states have passed these laws, but we also think that there's a lot of opportunity for other states to sort of set some kind of goal and let the market then operate, or place some guardrails around the market and let the market operate around those. So next slide. So cost growth targets are a maximum target expenditure for the state, the maximum that the state wants to spend in healthcare over the next year. And California actually passed these as part of the Office of Healthcare Affordability. They go into effect in 2025, I think, with enforcement. And they typically, so they take the baseline spending and then they set a percentage of increase that they would like to stay under for that. And they may include performance improvement plans or even financial penalties for health systems, payers, et cetera, that exceed that threshold. And as you can see, a few states actually have these in place, and it is kind of a growing among especially the blue states as a policy option to at least understand and begin to address healthcare spending. And Massachusetts was the first to adopt these. They adopted one in 2012, and researchers have estimated that it saved the state about $7.2 billion. That's a cumulative number between 2013 and 2019. The early success appears to be waning because in the last few years they exceeded the growth target. There is some question, of course, about the coronavirus pandemic playing a role there. But I think overall there is some evidence that these mostly have a naming and shaming type enforcement, that many times health systems don't want to see their names there on the list of reasons that the state was unable to meet their targets. But as the system gains market power and that becomes less of a shaming tool, I think they may have less effect. The second one I'm going to talk about really briefly is a public option. Now, state public options are state-initiated insurance plans that are offered to a portion of the commercial market. Typically, these plans are sold on the exchanges or to the individual market. And their premiums are set to cover the average medical expenditures. And they can also offer access to federal subsidies, et cetera, that people may be eligible for on the exchanges. 3 states have actually created public option plans. Only one is could you actually have purchased this year, but you can start buying them in Colorado next year. The major trade-off in these plans is to try and figure out how you can get a broad provider network at reasonable rates. Because if you set your rates too low and you let providers opt out, you're going to have a very small network. It's not going to appeal to anybody, and it's not really going to move the market. If you set your rate too high, you're really not going to save any money. And that was actually the experience in Washington. The rate was set relatively high. It was set at 150%-ish of Medicare, and basically the public option was no cheaper than other plans because that rate had been set through the legislative process and as a part of compromise. That rate really didn't save them much money. I'm happy to talk about any of these in more detail, but I really want to emphasize Colorado because I think they have a very interesting way to think about this what I'll call rate setting, because they basically set premium targets. So the premiums can increase more than this amount, and you still have to abide by state network adequacy laws. And these are laws that apply to all commercial plans that sort of set minimum numbers of providers or maximum travel distances for patients. And Colorado says, here's the maximum premium increase, and actually it's a premium decrease. We're going to let the market figure out the best way to handle that. But if there's a dominant health system, if an insurer comes to us and complains that some dominant healthcare system is making it impossible for them to fulfill both of those requirements, they can't reach the premium reduction targets and fulfill network adequacy laws without this hospital, then the State Insurance Commission can step in and hold public hearings, and the State Department of Insurance can say, health system X, you're going to participate in the public option, here's what you're going to be paid. And it's set in the instance where the industry has really failed to reach some kind of consensus. Next slide. And the last of these 7 options, I'm not going to talk about sort of the more restrictive rate setting. The last one are affordability standards. Now, all state insurance commissioners review plans before they're sold. But states actually have 2 different sets of authorities. Some states have prior approval authority that requires the insurers to actually get approval from the state DOI before selling their plans, and others have just file and use. The insurers just have to file the information with the State Department of Insurance before selling the plans. Now, the Affordable Care Act requires insurers in the individual and small group markets to justify the reasonableness of any increase of premiums above 15%. But it doesn't give regulators the authority to reject any of those rate increases that they find to be excessive. So affordability standards allow the Department of Insurance to do that. They allow the insurance commissioner to simply say you may not sell plans that we find to be unaffordable, and they define affordability as a % increase that's often tied to income or state gross product. And the one state that has had real success with this, or the one state that's had it for more than a few years, is Rhode Island. And I'm going to talk about Rhode Island for just a minute. Rhode Island is unique in that they have a separate health insurance commissioner that's separate from the rest of the insurance department. And OHIC actually looks at these plans, and then they have the authority to look into these contracts and say whether a particular hospital is causing any excessive increase. And the evidence is that they successfully reduce spending on hospital care relative to a national cohort. So they actually saved substantial savings. However, because they have a percent increase, it exacerbates existing disparities between health systems. So if you're allowed a 5% increase, 5% of a bigger number is a bigger number. So if you were already charging excessive rates, your 5% gives you a bigger price bump than at the bottom. Now, Rhode Island came out with recently revised revisions that allow a one-time correction for this for anyone that is below the state median. They can have a one-time bump up, but again, this percentage increase just exacerbates those problems. And again, Rhode Island's affordability standard is only specific to hospital care. That only has the authority to look at hospital care. And so there's some evidence that physician prices are some of the highest in the country in Rhode Island. And there's been great consolidation among providers in Rhode Island, probably because a lot of health policy can be a game of whack-a-mole. So you push down on hospital care or you push down on prices in some part of the delivery system, and they pop up somewhere else. So I'm happy to talk about any of the others if you want to later. But I think I'm coming to close to the end of my time. And what I really want to emphasize on this slide is that there are lots and lots of options. If we talk about rate setting, we don't necessarily mean the state's going to step in and say, you're going to pay X dollars for whatever treatment, right? States have the ability to think more broadly about how to best serve their residents and how to have policies that protect their access to health care. Next slide. And before I finish, I just want to point out that consolidation isn't just about prices. So this is from a news story from May that found that this is specific to Connecticut. So in Connecticut in 2000, most of the hospitals were independent hospitals. You can see that 23 hospitals were independent in Connecticut. And then in 2022, only 7 hospitals are independent. And this reporter actually looked at the hospitals that were being closed, and she found that there were 5 hospitals that were applying to reduce services, were applying to the state certificate of need program to reduce services. They were all in low-income areas. They were in minority communities. For example, there is a town that was 70% Hispanic in Connecticut, and they were looking to close their labor and delivery services. And so people in that community that were having a baby were going to have to drive more than an hour to the nearest hospital. And so, these people, and it was all in the name of cost savings, right? The health system was claiming that they could deliver better care if they just consolidated all their services in the big cities. And a lot of rural communities are losing access to care, especially for things like labor and delivery, inpatient psychiatric care, and ICUs. And this is a real problem as it exacerbates all those disparities I talked about at the beginning. And I think it's important to note that we're sort of on the tail end of sort of a pandemic, or learning to live in the midst of COVID. And you can see that healthcare spending has sort of tracked GDP. In the middle here, I apologize that that's kind of light, but the ACA expanded coverage there in 2014 to 2016, and then healthcare expenses kind of exceeded GDP for a while there. And then you can see what happened last year. And that is the result of a lot of government money infusion into our healthcare delivery system, which I think is exceptionally important. But I also think that it's unlikely that a hospital is now going to say, okay, COVID's over, we got the money, we're going to reduce our prices by 50%, bring them back to pre-COVID levels, and we'll all be good. I don't anticipate that happening. So I think this slide just emphasizes the need to act now, or this whole delivery system will be a problem. And then finally, in summary, it's just time to face Goliath. So the consolidation is a big issue that's driving these unsustainable price increases and exacerbating issues of access and quality that exist in our country. And the lawmakers have a large toolbox of options, that it's time to start trying things. We don't need to have a conversation about whether we should move to single-payer healthcare. I mean, I think that the discussion is important, but we don't have to get all the way there. We can use some of these piecemeal or policies that really address specific gaps in our delivery system, and it's important to do that now. So the time has come for lawmakers to change a system that costs too much and fails too many residents. Thank you.
We'll now hear from our formal respondents. After each, Dr. Gudiksen will have the opportunity to reply. After that, we'll open up the floor to you, the audience, for your comments and questions.
Thanking you for your insightful presentation. A question that I had for you was that you mentioned that you mentioned that changing policies in healthcare was kind of like a whack-a-mole in the sense that reducing policies in one area might cause an issue in a different area. However, what would you say is the theoretical stone to facing this Goliath? If it wouldn't be policy changes, what would you say the first step, or the singular first step would be to start making these changes?
Yeah, thank you. I think that's a great question. I think the answer is that I don't necessarily think we have one stone. I think we have kind of a full toolbox. But I think if you're asking me what the most important first step is, I think it's actually these cost growth targets. I think in many states, people don't even understand what we're paying for healthcare. Are there communities that are really underserved? Are there access issues? Who's driving a lot of these healthcare costs? For example, healthcare delivery in many rural areas is actually quite expensive. It is really expensive to keep your emergency room open with no patients in it. But yet it's really important to have that emergency room open when you need it. And so one of the policy solutions I didn't talk about is actually hospital global budgets. And I think something like that is, well, a global budget actually would pay a hospital a given amount. That's their budget for the year. And I can get into a lot of details because there's fixed global budgets, flexible global budgets, et cetera. They all have kind of different trade-offs. But I would just say something like guaranteeing a rural hospital in particular, a budget is really important. And yet that's just a small fix. That's only going to fix hospitals in rural areas. But I think that that's really important. And so I don't necessarily think that there's one policy solution that's going to fix everything. We can look to our neighbors in the world. We can look at Great Britain. We can look at Israel, actually, Taiwan, all these places that are supposedly fantastic healthcare systems. They all have their own issues as well. And while I wouldn't argue, I certainly think they have there are particular advantages over our system. They have long wait times, et cetera. And I think the most important thing is to get the data to understand that. And these states that have cost growth benchmarks, they're reporting to their public. They're saying, here's our target. Everybody else figure out how to make this target happen. And then we're going to write reports about where we're falling short. And I think that's the most important first step.
Thank you.
Dr. Bailey, would you like to add?
Sure, thanks. Great talk. I appreciate all the economics in there about how competition really does tend to be an effective way to keep production high, prices low. But when you lose that and you get down to a few hospitals, or especially just one monopoly hospital, they have a lot of power and they tend to use it to benefit themselves. So my question is, you mentioned a couple of recent changes in the federal government where we have a new chair of the Federal Trade Commission, Lena Khan, and you mentioned the executive order from the Biden administration trying to move antitrust in this more aggressive direction of preventing the mergers that would create these monopolies. I was just wondering if you've seen any big successes from those efforts that are now 1 to 2 years in, or if not, do you think they're coming and it's just a matter of time, or that they're not able to do much with existing legislation the way it is?
Yeah, I think that's a great question. And I think maybe my first gut reaction is that antitrust is a very blunt tool. So it is good in the sense that it's flexible and it can address a lot of different harms to competition. But the Sutter case I mentioned took over a decade. And so patients were paying these allegedly excessive rates for over a decade, suppressing wage growth, having all of these other impacts on the economy. And yes, it's fantastic that we got to that end of that and we got kind of a historic damages settlement and these injunctive relief. But what I didn't mention there was that there's a similar case that played out in federal court, and that one went before a jury. The judge gave some jury instructions that I would say that the plaintiffs in that case objected to, and then the jury, I think there's pretty good evidence that the jury was confused. The jury actually found for Sutter in that case. And while it's being appealed, I think that shows exactly the risks of antitrust law when you're trying to convince, a group of lay people kind of the intricacies of competition law and exactly what's illegal and legal. And there's this big debate about whether Sutter is actually a competitor with Kaiser. If you know California, Kaiser's really a closed system, which in many ways operates kind of independently of a lot of other healthcare. And so, the plaintiffs alleged that they shouldn't be considered, and the defendant said that, Sutter said that really they were competing all the time with Kaiser, and these kinds of complicated decisions are really hard to play out in court. So I guess the first answer is I'm a little doubtful of antitrust law writ large solving any of these issues, and that's not to say it's not really important to get those right. I just don't think it's going to get us the whole way there. I also think, in addition to Biden's executive order, he placed Javier Becerra as the Secretary of Health and Human Services, which is really an interesting choice. So if those of you in the room remember, he was our Attorney General, and he was the one who actually started this Sutter case. He's an interesting choice to lead our Health and Human Services division because he's a lawyer. And I think that it really, emphasizes how important the competition issue is. And I think federal policy is in very much steering the ocean liner. And I think we're headed in the right direction with all of these policies, but I think it's really important for state-level policymakers, and that's why I do most of my work with the states, is figuring out how to move much more agilely and kind of fill in those holes. And while I'm hopeful that sort of Medicare policy, the Inflation Reduction Act, et cetera, there are things in there that I'm hopeful about. I really think it's important for states to sort of step into that void and really help move things along much more quickly.
Would you like to add?
I guess one quick follow-up, since you mentioned Medicare, you addressed a lot of the research about how consolidation tends to raise the prices that people are paying through private insurance. But Medicare is this big federal program, and they tend to try to set prices at the national level, with some minor adjustments. So I guess how do you see the interaction between consolidation and Medicare? Is Medicare part of the solution here? Is evidence against the consolidation thesis or what?
Yeah, I actually think there's two different answers, and just to sort of level the playing field, there's actually 4 different Medicare programs, but importantly, there's one that basically pays fee-for-service rates, and that's actually Medicare A and B, and you can automatically enroll in that. There's also a second bucket of Medicare Advantage, that's Medicare Part C, that you can opt into, and there the federal government pays private insurers to sort of implement the policy. I think there's pretty good evidence that when in this Medicare Advantage program, it is actually facing a lot of these same issues of consolidation, but then Medicare Advantage can sort of just up the per member per month rate that the federal government is paying. And so I think it's actually harming the federal government that way, in the sense that Medicare Advantage is facing all these private negotiation issues. But back to the fee-for-service side of things, I think that you're exactly right, that those rates are sort of set. I think we can talk about the details of whether that's done right or not, but I think in general, having a transparent price that everybody knows, and there's some geographic corrections, et cetera, in the Medicare rate, but I think it's really important to have these prices, and in particular, I think having the government try to figure out what a fair rate is, and I think we're going to hear later that perhaps they don't do a great job of that, but at least the attempt brings some transparency to the process and then allows states some ability to know what is a fair price. So I didn't talk about out-of-network caps, but some states are considering trying to cap the amount that insurers can be billed for out-of-network services. And I did talk about the public option as well. Some way of pegging rates to some national standard I think is critically important. So just having a Medicare rate where the government figures that out, I think is really important. And I think that in that case, they're not necessarily subject to the sorts of consolidation issues I talked about here, except to say that I believe the Hospital Association is the third largest donor to congressional campaigns. I believe pharmaceutical is number 1, I believe technology is number 2, and I believe the hospital system is number 3, which suggests there's a heck of a lot of political power from these large health systems. So it's not just financial, it's also political. And I do think, to the extent that Medicare policy is then affected by the people who've been paid by the hospital systems into getting into office, or the hospital system has donated money to their campaigns, I think that that's a real conflict of interest, and I think that that could be, the consolidation could sort of drive that in an indirect way.
Bailey, do you have any more comments or questions? Thank you. And now the floor will be open to you, the audience, for any questions or comments you may have. Professor Schubert will be serving as your moderator. Professor Schubert.
Thank you, Hema. As mentioned previously, this event is being recorded by Access Sacramento for broadcast on public access television and radio. In order to ensure that your comments or questions are appropriately audible on the recording, please speak into the available microphone. I know some of you have great lecture voices and project well, but still we need you to indulge our need for the specific technology. So if you're ready, approach the mic to the left of the stage.
I was impressed by the slide you showed early on, showing the variability in prices from the very same hospital for like a joint replacement. And this is going to be a naive question, but why aren't prices like that just like real estate prices, where I can go onto Zillow and look up a particular address and see in any state in the country, okay, what's that price for that house? Why aren't the prices that transparent for, like, if I want to get a joint replacement in San Francisco?
Yeah, so I would say the first answer to your question is that basically for a very long time, the companies claimed they were trade secrets. If the public would know, we'd get a worse deal on our negotiation. And that's actually why those, the price transparency, the federal price transparency rules that I talked about, those were actually a Trump administration policy. And one was to require all hospitals to disclose all these prices. And the second was to require all payers to disclose, and employers to disclose what they paid for services. And there was some hope that there could be some kind of reconciliation, et cetera. I'd say there have been some growing pains there, maybe to put it lightly. Actually, one of the things mentioned in that executive order was that hospitals had just decided not to comply with this. They said it was too hard, we're just not going to comply. There was a financial penalty, we'll just pay it. And so the executive order actually increased the penalties on those hospitals for noncompliance. And so I think the data is just beginning to trickle out, because for the longest time, everybody claimed it was a trade secret. And that's in the best interest of the health system and the insurers, because as I was talking about in Massachusetts, right, they can just pass all that on to employers, actually, the government in the form of, as you're talking about Medicare or Medicaid payment, et cetera. So basically, they were just considered trade secrets. And I would also argue there's a lot of things about healthcare that make it not operate like real estate or like purchasing of, I don't know, a handbag or a car, et cetera. So insurance shields a lot of us from our price. So I often, when I go to the doctor, I don't know what it's going to cost. I'm going to choose to purchase that almost regardless of cost, especially if we're talking about essential medical services. So there really is no price shopping among patients the way there is for, say, real estate or cars or anything. So there really wasn't maybe perhaps the demand for those prices among patients. And so I think it's only becoming, as we're getting the data, it's only becoming more and more clear how important, how critical really that data is to academics, to advocates, and to policymakers.
Thank you so much for that very interesting and informative talk. I had several different questions, and I think I'll just focus on one. And I feel like you've answered this question at the end of your talk and other parts of my question throughout. The question is, what are some of the main reasons given against state and federal regulation and against giving oversight committees real power, authority to reject merger proposals or to set rates? Is the reason partisan? Is the reason because of the powerful special interests that you mentioned earlier? If the reasons are partisan, I wonder, and again, you may have answered this question already, are there any market-based solutions or private solutions that you can offer?
Yeah, there's a whole bunch of things I'd like to say to respond to that. That was a great question. I think at the highest level, a lot of the policies that we're talking about sort of are partisan in the sense that there's always this debate between free market and regulation. And I think for the longest time, one of the reasons the FTC lost so many cases from 1991 to 2011 is that judges were saying hospitals were nonprofit. They're going to do the right thing. We'll let this merger go through, even though there are these competition issues that kind of the FTC is raising, et cetera. And so I think that there's becoming a lot more realization, I think, that healthcare is sort of a special industry, both because of what it delivers, but also because of the consolidation that's been allowed to happen. And so I don't think that all of the policies I've talked about here are really partisan. In particular, the contract terms, the laws banning contract terms was something I talked about. It's actually, the Republicans have a Healthy Families Committee that they put out what they think are healthcare priorities for the country, and they've actually included some of this there. So to the extent that some of these are pro-business solutions, I think there's a realization that this is really harming employers and driving down wage growth and really crippling the whole economy. And that's something that even conservatives want to get behind because they want and we all want a functioning economy, but they're recognizing that the time may be coming for some kind of government intervention. Like there was one other part of your question that I wanted to respond to. Oh, why aren't there more, what's the argument about giving sort of state agencies more authority? And I think, in the policy wonk field is well known, but in the 90s, there were 8 or 9 states that actually just set rates. There were states that just said, here's the rate that we're paying for healthcare services, and Maryland actually continues to have a similar system even today for hospitals. There's some evidence that they didn't do a fantastic job of keeping prices low. And part of that is that in this fee-for-service system, hospitals could make up any lower amount in rates by increasing volumes. And so if you weren't really careful about the way you wrote these policies, you could wind up actually increasing costs. And there's some evidence that in some states that happened. And then there also was a lot of regulatory, both capture and failure at that time, and that means basically the hospitals or providers actually had a lot of influence on what rates were set, and so you can see how that would be a problem. And so I think that that's something that often gets brought up when people try and, it's almost a non-starter. It's, like I said, kind of the third rail about rate setting. And I think that's still true, especially in the deep red states. But I think it's important, and I think that there's a lot of realization that we don't have, rate setting doesn't mean these commissions of the 90s, and sort of thinking about that issue more broadly. When I was comparing sort of Massachusetts and California to Oregon, I think it's interesting that Oregon actually has an administrative process to review them, while the other 2 states decided they wanted to be more of an advisory office that then gave a report and sort of an informed recommendation to the AG, but the AG still had to go to court. And I think that is sort of a tension. That's just kind of embodying the tension that's playing out here between regulation and market economy.
Thanks very much for all your work on this. I wanted to connect 2 things that you've said in your talk and maybe get your informed opinion about how they connect. At the end, you expressed some concern about campaign finance and lots of hospital system money going into I assume, state and federal level political campaigns. In the beginning of your talk, you expressed some optimism about at least some states, maybe Oregon, creating, a regulatory commission or a quasi-independent panel that would do have some influence at the state level on what's happening there. So this is maybe, excessively cynical on my side, but my suspicion, I don't know anything about what's going on in the details here, but my suspicion is that those sorts of commissions all get populated with political appointments, and a lot of that campaign money influence is going to feed into both the powers and the configuration and the composition of those panels. So what do you think about how do you justify your optimism about those state agencies being able to do that? We've had this classic problem of sort of revolving door problem at the federal level where, my bet is it's a hospital administrator who then goes to work on the regulatory agency that's overseeing the state's hospital system.
Yeah, so I have two responses, and the first is sort of a very quick response in that those states absolutely recognize that. And like I said, I was just at the launch party for OCA on Wednesday here in Sacramento. The thing that they are the most proud of is the fact that there are very tight restrictions on who can serve on the official committee in California. There's a separate advisory committee where they take people from industry, but anybody serving on the committee itself that's making the decisions can't get any compensation from basically any healthcare entity that's defined in statute. And it's quite a strong restriction, and actually, maybe not surprisingly, the industry is arguing that they're going to have a whole bunch of people who don't know anything on this panel, and I think they'll have to choose carefully. I mean, that's the counter argument, of course. But I think that exactly what you're saying is something that these states are really recognizing. But I think your point is very valid. I think that to the extent that the governor is appointing things, or even the legislature is deciding all these policies, I mean, I can only wholeheartedly agree, and just hope that as we make these issues that much more transparent, as things like those. I didn't put up data from the New York Times, but the New York Times had a big expose that was sort of similar to the price disparity data that I showed. That was from a different article. But as these things get broadcast across the New York Times, then it becomes clearer and clearer that healthcare prices are way outpacing inflation. So your employer is paying a whole lot more for your healthcare, so you're not getting much more in take-home money. I think that is something that I'm optimistic that that's something that voters will recognize, and that it will become less and less acceptable to take large amounts of money from hospitals. It used to be that the insurance companies were the bad guys, so it was completely safe to take money from hospitals because they're the good guys, they're your doctor, et cetera. And I just think that perception might be changing, and maybe that's why I'm optimistic. But I certainly take your concern for sure.
Is there any relationships with the consolidation to the overall degree attainments in a society, say the United States, from, say, the 1980s over a period of time until today? So if there was a loss of degree attainments in healthcare, does that result in this type of consolidation, or has there been an increase in overall degree attainments in healthcare? That's what I'm trying to see if there's any type of relationship between those.
By degree attainments, do you mean like number of doctors, number of nurses?
Yes.
I think the number of doctors has been fairly constant and sort of a slow increase over that time. I know there's always a big push for more nurses, and I know there's a lot of nursing school. I don't have actual data on sort of anything other than physicians that's sort of been a general increase. Yeah, I don't know if there's really a correlation between those.
First of all, let me introduce myself, and so you can see why I would know more how to change this better than most people can. First of all, my name is Michael Horn.
Michael, I appreciate your interest in letting us get to know you, but the appropriate thing to do right now is to ask a brief question of our
It's a
speaker.
comment too, and I actually have the power to change it, because how can a politician who can't cite the Constitution make these laws? How would they know how to make laws that don't violate the homeless rights if we've never been homeless? Or create laws that if we've never been disabled, but yet violate that disabled? I actually live with ADHD. I also was a former foster youth and even homeless. And I am on SSI Social Security. And I could cite the whole Constitution by memory. And I live with ADHD. So I'm twice exceptional in criminal justice and in the legal field. And I could cite the whole Constitution. So I am the best person to actually put the law. So and one way to change it is make people who are low income disabled, and people like that being the politicians making the laws, because they are the ones who could really advocate for the low income because they've been there.
Yeah, I would actually totally agree that I think that it is really important. I think for a very long time, the people who contribute money, businesses, et cetera, have the loudest voice. I hope I'm not a delusional optimist, but in Oregon, they actually, every merger, it's sort of a two-tiered process, but any merger that gets to the comprehensive review, the state of Oregon tries to convene an advisory council that is made up of patients in the area that would be affected by this merger, and to hear their stories, and to hear, if we closed L&D, where would you go to have your baby? Or would it be more important to have these services or those services, or is the problem that a Catholic system is taking over and you're going to lose sort of, Oregon has a big push for death with dignity, and that's been a real concern there as the Catholic systems take ownership of a lot of the hospitals. I think we can always do better, and absolutely we can always do better. But I am very optimistic that at least there's an attempt to get those voices, that there is at least written into these laws the need to think about equity and not equity from on high, right? To hear from people in the community about how things like antitrust law that really have, at least, at first blush, have little to do with people on the ground who are just trying to get basic health care. I think that recognition is there, and it's just a matter of being a part of the process. So making sure that if you can serve on one of these committees, you do, that you put up your hand whenever you can.
So this question might seem not so surprising since I'm your fourth speaker and we'll be talking about definitions of affordability, but I was very interested in the discussion of state insurance affordability boards or definitions. And what I was curious about was how states that have used this policy tool have approached the question of how they define affordability for insurance and how this resembles or differs from efforts to define affordability for other types of essentials like housing, utilities, or education.
Yeah, that's a great question. To sort of answer the technical question, there are 3 states with affordability standards: Rhode Island, Delaware, and Colorado. Delaware's were passed 2 years ago, and I think they've just been implemented. And Colorado is actually working on the public option that I talked about, so they've kind of postponed this. But in Rhode Island and in Delaware, affordability is set relative to increases in the CPI urban, so the Consumer Price Index for all things urban. So it's tied to basically inflation. And so the idea is that we should not be, that healthcare should not be taking a bigger piece of our wallet over time. In terms of definition, like legal definitions of affordability for things like education, et cetera, I think when I think about affordability, it's do I have space in all these pockets to pay for all the things that I need? And I think that this really fits into that because it's asking, we don't want healthcare to make up a bigger portion of that. Of course, this is affordability writ large, pretty much. It's not thinking about sort of cost effectiveness or any kind of those affordability for drugs, et cetera. So I think it does fit with sort of general conceptions of affordability for education, housing, et cetera.
First and foremost, I'd like to thank you for the very thought-invoking presentation and talk. The part I took particular interest in was your mention of the cost transparency. I've recognized that there's sometimes miscommunication or unclarity when it comes to, for example, what is being paid for during what services are being paid for, and there's also like language barriers. Do you have any suggestions or proposals on what we can do to minimize those miscommunications so that people have a clear understanding of what services they're receiving?
Yeah, so the price transparency I've been talking about are sort of government price transparency. I think you're talking more about, does a patient know or can a patient get cost information when they are getting their care? And there are a lot of state and federal laws around that. I think the big question here is that people don't know that they can ask, and then hospitals and doctors, et cetera, have a hard time actually knowing what a service might. They know the range of services, but they're always going to claim that we don't know if you're going to need an extra blood transfusion, or we don't know all these sort of billable codes. And to some degree, I think they're right. And I think that there are state laws that require, elective surgeries. You have to get, if a patient asks, you have to give them that kind of data in advance. I just don't think that they're used that effectively. So rather than saying that I think we need new state laws, I think patients need to be able to know that they have the right to that information. I think part of the problem with these federal price transparency rules is that the amount of data is overwhelming, even to sort of the economists I talked to. There are these giant files that sort of people don't really know what to do with. And I do think that will be changing, but I still think that that's going to know people who are typically used to looking at reports and who are really engaged in the system are the ones who are going to be able to use them. I think big picture, I think we need to be able to have a healthcare system where people are not worried about paying the rent or paying their needed medical bill. And so rather than asking the consumer to be, or the patient to be the consumer, I think we just need a system that covers that writ large in a much better way.
You can focus on consolidation as a cause of market power. I think like you have, makes sense because the acquiring entity, leads to a more powerful entity with more market power. Might also consider consolidation as an effect of market power. And I wonder whether there's a general account that explains how these acquiring entities got the market power that led to these massive, was it a combination of market forces that predominantly explain where they got it, or political forces that explain how they got this market power to go out and start acquiring a bunch of stuff?
Yeah, I think there's sort of two parts to my answer to that question. And the first is really just, in the US, healthcare is a profit-making industry. And to the extent that you think you can charge higher prices and get more profit, you're going to buy up your competitors, and you're going to, get physicians to refer to you, and you're going to make sure those physicians, you're going to structure some employment and that they're not referring care to some other hospital. But I think that there's also a lot of sort of government policies, and in my mind, I'm thinking of the Affordable Care Act, which actually, requires or provided ways for providers to get more, to share risk. And by that I mean, there's some contract that says we think that healthcare should cost this much, and if you save us money, we're going to share that savings with you. That's some kind of risk. And sometimes there's downside risk too, meaning if you went over what we thought healthcare should have cost for this population over the time, we're actually going to make you pay us some money. And for a single practitioner, the thought of taking on risk is just impossible. So it really caused consolidation of physicians, and I showed the graph of physicians that are really becoming part of these large health systems. And I think there were a number of policies that were very well intentioned, but may have driven some of this consolidation. And in particular, in the merger guidelines, there's actually some safe harbors for affordable care organizations, et cetera, that are intended to improve care at lower costs. And I think that, it's hard to be critical in the past because they were such well-intentioned, but I don't think that I think their track record is mixed at best, and perhaps it's time for more guardrails around that sort of consolidation.
Hi, thank you for your talk. I have a quick question. You began with a slide with a comparison between the US and other countries with respect to healthcare, and what are they doing right? Have they solved the problem of consolidation and have more competition, or is there any other thing that they're doing, and whether those things that they do are plausible to be done here? I know this is very general. But.
Yeah, I think in general, healthcare is not intended to make money in any of those other countries. In almost all of them, the government just pays for services. It's, it's not, there's not some negotiation behind closed doors where I'll charge you a little money and then we're going to make sure that we're disadvantaged your rivals, and then that's going to come out in the end. So I think having a government system that does the payment can be that's one of the reasons that they're lower cost for sure. I think that has all of its own issues. For example, the British system is sort of infamous for long wait times, but one of the things that they do in primary care is they give their doctors sort of a per patient amount, and then the primary care doc, has a portfolio of patients that he or she sees, but he doesn't make any more money, he or she doesn't make any more money if he orders extra tests for that patient. In fact, he actually does a little better if he keeps his patients healthy because they don't have to come into his office, and so he can see them all in a reasonable amount of time, and maybe he can take on a few more patients. I think that sort of specialty care in the British system is a little more complicated. I think all of these systems have sort of their individual problems. The Israeli system, for example, actually set up 4 different insurance companies that are all nonprofit and make them compete with each other, and the government sort of oversees them. So it's sort of like managed competition, and sort of, the government set up very specific competition, et cetera. And so there is some ability to allow some market forces to sort of increase quality. But I think each of those dots has their own way of doing things. It's just always so striking to me how there's sort of a cluster in the middle of sort of European and other high-income Japan, et cetera, high-income countries, and then the US is the outlier on any graph you want to look at.
I had a question that I would like to add to the topic of consolidation. So would you say that promoting competition between different health institutions is an effective way to combat consolidation, or would it inevitably lead to discretion in prices and price increase in certain, and basically just more on the competitive side of marketing? Would it cause issues in the future?
Let me make sure I understand your question. Are you asking me if there's any cases where consolidation might be beneficial? Is that your question? Or are you more asking, would it always be better to have, say, 2 hospitals in a market because they'd compete with each other?
Well, I guess I'm asking a 2-part question. The first would be, is competition an effective way to combat consolidation? If so or not so, well, if so, would it lead to pricing discretion and different marketing, and that could lead to competition between different healthcare providers?
Yeah, I think part of my wanting to refine your question is that, to me, almost competition and consolidation are almost opposite ends of the spectrum. So competition sort of, if you can get more entrants to enter the market, that would improve competition and, at least in theory, drive down prices. I very much hesitate to say that's the solution in healthcare, because I think in many places the answer is not open another hospital. I think we'll hear later about CON laws, but historically those have been, in the fee-for-service model, having more beds, hospitals want to fill them, and then they can drive up prices. I think what we need is actually more, a more level playing field, and a recognition that government really should be playing a role for healthcare, that it is not a traditional entity, and that where competition exists, fantastic. If you've got 4 cardiologists and one provides a much higher quality care, she should be able to take as many patients as she wants to, et cetera. I think competition in healthcare can drive quality, especially if we sort of start to cap rates, and I didn't really get into this, but in some of those systems, the British system is one example, by capping the rates, doctors start to compete with each other for things like, is my waiting room nice? I mean, things that maybe wouldn't matter in a traditional market, but actually do matter to patients, like how fast can I get an appointment, et cetera. And so I think that when I first heard your question, like the distinction between competition and consolidation, I was sort of confused, but I think consolidation with the right guardrails can actually lead to competition on non-price dimensions. And I think that's an interesting way to go, and I think that is something we're sort of thinking about.
Thank you.
Unfortunately, we've reached the end of our session. Fortunately, there is more to our symposium. For now, please join me in thanking our session chair, our respondents, and most especially our presenter. Our next session will begin shortly on the hour.